A very good afternoon from Bahrain. We are 1 hour behind UAE time. Thank you very much for the kind introduction. I hope you can hear me. Okay, so in the next 20 minutes or so, I'm just going to give a very short presentation, but I thought I'll put this question in front of the audience. And your job is to pick the right answer. The question is, which of the following statements is correct? And the options are A, lipoprotein small a, and apolipoprotein capital A are similar in structure and function. B, 1 in 5 individuals have high lipoprotein small a. Till date, there is no therapy for lowering lipoprotein small a. Apolipoprotein B carries cholesterol from peripheral vessels to the liver. Or E, high ApoB ApoA ratio is desirable. So anyone wants to shout out the answer or put it in the chat box? Okay, anyway, so in the next 20 minutes or so, I'm going to talk about what are lipoprotein small a, and this I'll be referring as LP little a for the next of my talk, and apolipoprotein B. I will then be giving you some information as to what is the cardiovascular risk that is associated with increased LP little a, and what are the current therapeutic options that are available to treat LP little a. So lipoprotein small a or LP little a is like LDL, and except that there is a second atherogenic apolipoprotein small a or ApoA that is coiled around it. Now, this is a molecule that is not new, and this has been known since 1963. And this was discovered by the Norwegian scientist and researcher called Cardiologists. Now, it is an irony that after nearly 6 decades, we are still are not very familiar with this molecule. And the reason it has come to light, now we have recognized that LP little a indeed is a factor that determines a significant future cardiovascular risk and also cardiovascular death. If you look closely at the structure of the LP little a, this is basically LDL-like lipid core. And if you can see my cursor here, so this is a coil-like structure with small loops, and these are called kringles. And that is attached to another sticky or atherogenic molecule called ApoB100 with a disulfide bond. So it's a LDL-like particle, but it has got a atherogenic loop and another atherogenic particle called ApoB100, which I'll also be talking about in a moment. There are 2 isoforms, and these two isoforms, they differ in their molecular weight. So there's isoform which has got large molecular weight, and they have got more number of kringles here. And there's a smaller molecules with smaller molecular weight. They've got smaller number of kringles. Now, the difference is that the smaller molecules are more atherogenic. They cause more stroke and more cardiovascular events. It is genetically determined, and it is the LPA gene that is responsible for increase in the level of LP little a. And this gene is found on the reverse strand of chromosome 6, Q27. And this is an autosomal dominant condition, which means if somebody has got elevated level of LP little a, then he or she is going to transmit the same, and the children or the siblings have got 50% chance of having inherited and elevated LP little a too. Now, how common it is, I'm not sure how many of you are sitting there in the audience, Now, if you are in a group of 5, then if I test randomly for all of you, we'll see that 1 out of 5 of you will test positive for elevated Lp(a). So it is that common. So the prevalence is almost 20%. So 20% of the individuals worldwide, they have got elevated Lp(a). So it is that common. But sadly enough, this is not tested routinely. And the figures from United States reveal that less than 1% of the US population are currently tested for the Lp(a). So it is a global problem, and the elevated Lp(a) is present in at least 1.5 billion people all across the globe. It has got some geographical variation, and there's some ethnicity that determines its prevalence. So it is more prevalent in the African individuals and also the South Asian population. And if you look at the prevalence of familial hypercholesterolemia, which we think is also quite common, but the prevalence is 1 in 300 people of 300 people will have high familial hypercholesterolemia, but 1 in 5 individuals will have high Lp(a). So it is that common, and it is much, much common or more common than familial hypercholesterolemia, which we know for a long time now. So what are the cardiovascular risks associated with a rise in Lp(a)? Certainly, it increases your chances of myocardial infarction by 3 to 4 times. It increases your risk of stroke by at least 1.6 times. It also increases your risk of cardiovascular death and all-cause mortality, peripheral arterial disease, and also aortic valve stenosis. Now, how does it cause aortic valve stenosis? Now, when you have high levels of Lp(a) in your blood or plasma, it increases the calcification in the aortic valves. And also there is deposition of the oxidized phospholipids in the intracellular space of the aortic valves. And that's how it increases the calcification of these valves and can eventually lead to aortic stenosis. Higher the levels of the Lp(a), higher is the chance or the risk that increases of cardiovascular events in the future, and also the risk of cardiovascular death. Now, we all know that LDL is a risk or a marker for future cardiovascular event and cardiovascular death. And this, we know it for a long time. This is not something new. And what we do, we routinely test for LDL. And a lot of research are actually based on LDL. Statin trials, they're all based on LDL levels. How much LDL is reduced on which kind of statin and what is the cardiovascular event reduced. Now, if you take that LDL and put that into equation for assessing the primary and the secondary risk for any future cardiovascular event, now we may classify that individual or a patient at low risk or intermediate risk. But if we add to that equation the measurement of the Lp(a), then you'll find that the risk is substantially higher. So a low risk or intermediate risk individual may become high risk or very high risk or extremely high risk just based on the Lp(a). So it is that important. So it helps us to identify the risk. It helps us to risk stratify individuals and patients in a much better way for future cardiovascular event and cardiovascular mortality. So who should be tested for the Lp(a)? Now, there are guidelines from number of international societies, and most of the societies actually agree that if there is a family history of atherosclerotic cardiovascular disease, then definitely you should test for the Lp(a). And also, if there's a personal history of premature cardiovascular disease, then some societies agree that you should test for Lp(a). But also, there are some societies who believe that you have got a moderate to high future risk of cardiovascular disease, or your LDL is very high, and particularly if they are resistant to statin therapy. That means if you give statin to lower the LDL, the statin usually does not come down, which is called statin resistance. But there are a couple of guidelines and societies which agree that it should be tested in all individuals at least once in a lifetime. That is the Canadian guideline and the European Society of Cardiology and European Atherosclerotic Society. And if you ask me personally, I have advocated the same prophecy that it should be tested for everyone. Because if you do not test it, you'll never know. And you'll not know not only your LP-little-a, you'll not know what your future cardiovascular risk is. So if you have not tested yourself for your LP-little-a, then I would highly encourage that you go back, either request your doctor or your physician or a cardiologist to test for your blood for LP-little-a, so that you know whether you have a risk, increased risk or not for future cardiovascular event. Now the test is very simple. All you need to do is a blood test, like you give a blood for a lipid panel or lipid profile. But mind you, the lipid profile you may need to fast just to look at the triglyceride level, but you do not need a fasting sample. Now, the only problem with this test is that not all labs conduct the test. In our hospital, we do not do it locally. We actually send it to Dubai and UK to do these tests. Now, these tests are not very costly, but not readily available. And what are the normal limits? Normal limits actually starts from less than 30 milligram per deciliter. But if you look at the risk of cardiovascular event and cardiovascular death, they usually start above 50 milligram per deciliter or above 125 nanomole per liter. So obviously, once we identify the LP-little-a, now until recently, when I used to test my patients for LP-little-a, they used to come back for the results, and I used to give them results that were high. Now, it used to be quite an embarrassing situation that when I tell them that there are no treatment available. So until recently, that was the case, that we did not have any approved treatment. But over a period of time, thanks to science and medicine and new innovations in medicine, that we do have some treatment, and there are few treatments already available, and there are some in the pipeline. Now, first to start with the basics, and you may ask the question, does exercise and diet, or in other words, lifestyle change, does it reduce LP-little-a? Then the answer is no, they do not. But should you not advocate diet and exercise for these patients? The answer is yes. Why? Because if you diet low cholesterol, low fat diet, low carbohydrate diet, and also exercise, then you're going to reduce the general risk of future cardiovascular event. But per se, it is not going to reduce your LP-little-a. How about the statins, which we use so commonly to reduce LDL or bad cholesterol? Statins, they will not reduce your LP-little-a. And there are some theories that it may actually increase your LP-little-a, although it helps to reduce your LDL cholesterol. There are few agents we know for a long time, such as niacin. Niacin was developed for dyslipidemia mainly to increase the HDL level, but we all know that it does carry with it some adverse effects, GI bleed, gastrointestinal intolerance, flushing, and so on. But it has been shown to reduce the LP-little-a by 20 to 25%. But the negative part is that once it was studied in trials, it did not reduce any cardiovascular event. So yes, it can reduce LP-little-a, but it has no benefit on future cardiovascular event. Now, what we are left with is PCSK9 inhibitor. I'm sure you have heard of this. And this was developed to reduce your LDL level mainly. And there are a few of them, alirocumab and evolocumab. These are the common ones. And they have been studied in trials like Fourier trial and Odyssey trial. And they have not only reduced LDL by 60%, but they have also been shown to reduce LP-little-a by 25 to 30%. And in addition to that, they have also been shown to reduce your cardiovascular outcomes, and which is much of it, or partially it is attributable to lowering of the LP-little-a. Now, if your LP little is quite high, LDL level is quite high, at least more than 60 milligram per deciliter, then there are guidelines. You can use lipoprotein apheresis, which is like hemodialysis. So it just cleans out your blood of these harmful particles of LP little a as well as LDL. And this has also shown to reduce LP little a by 60 to 70%, and also reduces your cardiovascular events by 80%. So this is quite promising treatment available. But the downside, it is invasive treatment. The patient needs to go to the hospital and has got to have a daytime procedure at least for a good number of hours, at least twice a week, and it is costly. Lastly, what are the RNA targeting therapies? These are still much in trial, except for one or two medications that we have available. And there are two types: antisense oligonucleotide and short interfering RNAs that target the LP little a and can reduce it by at least 90%. So that's quite impressive. So these are some of the antisense oligonucleotides and short interfering RNA therapies that are available. So first is the pelacarsen, which is antisense oligonucleotide, and it has been shown to reduce in the trials the LP little a by 80%. This is taken as subcutaneous injection once a month, and it is currently being studied in Horizon trial, which will come to an end by end of next year. Now, inclisiran is a short interfering RNA, and it has been shown to reduce the LP little a by 20 to 25%. And this has been studied in Orient trials, and they have all been completed, all these trials, last year. And as a matter of fact, this medicine is available in the market in the form of subcutaneous injection. And I've actually tried this injection in my patients, and it has been shown to reduce LDL. It's mainly developed to reduce the LDL by 60% or 50%, but can also reduce LP little a. So there is a ray of hope out there in the horizon that these can help to reduce the LP little a. Now, the downside is that it is costly. One injection costs more than $3,000 US dollars. But the good part also is that you require one injection at once, and then you give another injection after 3 months, and then you give one injection every 6 months. From there on, you'll get only 2 injections per year. Okay, so that's the good thing about it. Rest of the medications that are mentioned here, they are still in trial. So hopefully in the next few years, we'll get some some positive results from these trials, which could be useful to reduce the LP little a and reduce the cardiovascular events. Now, how about aspirin in patients with already who have got cardiovascular risk and have developed future cardiovascular events? Now, this has been very recently studied and published in just January this year. And aspirin given to the patients with high cardiovascular risk and high LP little a has shown to reduce cardiovascular events. And if you can see my cursor here, so in the I would say violet or purple, these are the patients with high LP little a who are not given aspirin, and the red are the patients with high LP little a who receive aspirin. So the patients who receive aspirin against patients who did not receive aspirin with LP little a which is elevated, there is a 46% reduction in cardiovascular events in favor of those patients who have got elevated LP little a and those who took low dose aspirin compared to those who did not. So aspirin is now indicated in patients who have got increased LP little a and particularly for secondary cardiovascular prevention. Now, what is the European Atherosclerotic Society consensus 2022? That once you measure the LP little a, should be measured at least once a lifetime in the adults, and the LP little a should be taken into context of the global cardiovascular risk. And of course, to start with, you have got to intensify the lifestyle management and modify the other medication that may be helpful to reduce LDL, you control your blood pressure, control your sugar, and so on. And on top of that, if you want to add, then you can use specific LP little a lowering therapies which are available, or the ones which are still in the trials, which I've listed in my last slide. So very quickly, I'll discuss about the apolipoprotein B. Now, apolipoprotein B is another atherogenic molecule that surrounds the lipoprotein or LDL molecule. And they are mainly of two types, ApoB48 and ApoB100. So ApoB48, they are larger molecules and they surround the chylomicrons and the chylomicron remnants. But ApoB100, they are present or surround or encircle the VLDL, LDL, as well as LP-little-a, which I described previously. So same things here, but in addition to that, there is another protein, this ApoB lipoprotein, and there's another one called ApoA1 lipoprotein. So what are these ApoA1 lipoprotein? These are the ones which attach to SDL, and SDL, as you all know, is good cholesterol. So SDL is here, and you've got attached ApoA1. So what this does, it carries the fat from the peripheral tissue to the liver. So it is actually anti-atherogenic. On the other hand, ApoB carries the fat cells from the liver to the peripheral tissue or the blood vessels, and it is atherogenic. So this can lead to more plaque formation, more clot, and this will work opposite. So SDL will reduce the chances of atherosclerosis and plaque formation, future heart attack and stroke. So that's the major difference. And what you do is you take the ratio of ApoB and ApoA1. Now it has been recognized that amongst all the other risk factors that you can see here, BMI, HbA1c, HDL, LDL ratio, and so on, it is one of the most important determination or the variants that you can measure, and they to determine the cardiovascular risk or future cardiovascular risk for a patient. And there are some numbers here. So greater the number, of course, in men and women, greater is the cardiovascular risk. So this is the ApoB, ApoA1 ratio. More the ratio, both in men and women, higher is the cardiovascular risk and also risk for cardiovascular events. Now, what are the therapeutic options? How do you lower the ApoB? Number one, yes, here lifestyle change will help. So if you do, strict dieting, reduce your fat intake, reduce carbohydrate intake, so that is going to help to reduce ApoB, but it's not going to reduce lipoprotein small a. Yeah, and exercise, of course, you can use. And statin has been shown to reduce ApoB, so that's why statin is helpful, but it is again not a very significant reduction by statin or fibrate. But what might help is something is still in the pipeline is another specific antisense oligonucleotide, mapomersen. It's still under trial. So this is something we should be looking for if we want to treat and lower ApoB. Statin I mentioned, yes, it helps to reduce LDL cholesterol. It helps to reduce non-HDL cholesterol, but it has got some moderate effect on reducing your ApoB as well. So yes, so statin can be used here, but the fibrate is not very effective. So take-home messages are LP-little-a has got a high prevalence, but not often tested. LP-little-a and ApoB are more important predictors of future cardiovascular risk than LDL that we knew for a long time. And now there are clear indications for testing LP-little-a. So we all know I've discussed some of the indications, but I still advocate that every individual should be tested. Now the LP-little-a goes up. I mean, a person is actually or is born with LP-little-a, but the level is usually tested at 5 years of age. So this level can reach the maximum up to 5 years of age. That's the guideline to test for LP-little-a. And once you have tested, you do not test it again because that level will continue throughout your life. So you're born with LP-little-a level. It may go up maximum up to year 5. Then you do not need to test again. So it will continue the same level up to the age of, till somebody is, coming to the death. Okay, so treatment options are still limited, and I've gone through some of the treatment options that are available. And I have also mentioned that there are few trials underway for these treatments. So with that, I finish my talk here. And if there are any questions, I'm ready to take. And thank you very much for your patient listening. Thank you.